either side, connecting the epiglottis to the arytenoid cartilage on the same side, and functions as one of the factors in helping inversion of the epiglottis. This inversion acts as a sliding chute for food and fluid to glide over. The central part of the epiglottis is pulled up by the action of the hyoepiglottic ligament and forms a raised central ridge so that the bolus is shunted to the left and to the right of the chute. The overall benefit is that the bolus is diverted from the centrally located airway toward the lateral recesses called the pyriform fossae, which form a right and a left lateral foot channel. The epiglottis overhangs the airway opening and further safeguards the airway as the bolus is made to overshoot the airway and enter into the digestive tube. Aerodigestive tube is a term applied mainly to the oropharynx and to the hypopharynx. The buccal region may also be included if one is a mouth breather. The aerodigestive tube divides and separates into the anterior airway tube and the posterior digestive or foot tube, namely the esophagus. The introitus into the airway, the trachea, is called the laryngeal vestibule, and the two lateral recesses that act as introitus into the esophagus are called the pyriform fossae. The valleculae in the oropharynx and the pyriform fossae in the hypopharynx have a potential to retain solid or liquid material after a defective swallow. This is an abnormal and potentially dangerous condition as the retained material can be aspirated into the airway. The hyoid bone is also called the tongue bone, as the majority of the extrinsic tongue muscles are connected to the hyoid bone. Any significant movement of the tongue involving the extrinsic lingual muscle will cause the hyoid bone to move. The hyoid bone is connected to the thyroid cartilage, and the thyroid cartilage is connected to the cricoid cartilage. Since the thyroid and cricoid cartilages make up the outward framework of the larynx, the entire larynx closely follows the hyoid movement. 14 pairs of muscles are intimately connected with the hyoid bone, 3 pairs having their origin and 11 pairs being inserted into the horseshoe-shaped hyoid bone. Hyoid is the only bone in the body that does not articulate with any other bone, but is suspended purely on muscles and ligaments. As the hyoid bone is radio-opaque even in an infant, it lends itself to cine and video fluoroscopy as a reliable and useful landmark for patients of all age groups. During normal swallowing, the hyoid bone shows a typical valse movement which is coordinated with the movements of the tongue as well as the muscles of the pharynx and hypopharynx. The movements comprise the 3 steps of a valse. The first movement, when the hyoid moves anteriorly and upward, depicts the following 3 functions. They are 1. The transfer of the bolus from the buccal to oropharynx region. 2. The first peristaltic spindle contraction. And 3. Epiglottis position change from 12 o'clock to 3 o'clock. The second hyoid movement takes it posteriorly and is associated with the following 3 actions, which are 1. Transfer of bolus from the oropharynx to the hypopharynx. 2. The second peristaltic spindle contraction. 3. The epiglottic clock moving from 3 o'clock to 6 o'clock position. During this time, the first spindle sustains its contracted state and the larynx is still tucked under the tongue and the epiglottis overhangs the airway. The third valse movement shows descent of the hyoid bone to its position of rest and is synchronized with the following 3 events, which are 1. The bolus is transferred from the hypopharynx to the esophagus. 2. the third peristaltic spindle contraction takes place, and 3. The epiglottic clock, having reached the 6 o'clock position, flips back to its original 12 o'clock position of rest. Just below the laryngeal vestibule, there is an intrinsic laryngeal sphincter mechanism composed of a pair of cartilaginous masses. Each mass is composed of an arytenoid cartilage, a carniculate cartilage that is perched on top of the arytenoid cartilage like a cap, and a cuneiform cartilage resembling a wing raised overhead. These three pairs of cartilages, with their covering tissue, the false vocal folds, and the intrinsic laryngeal muscles attached to them, form two masses. These cartilaginous masses, one on either side, act like cymbals in the orchestration of the act of swallowing. When these cymbals come together, the combined clash closes off the airway effectively, giving us an example of the importance of the sound of silence. The muscles that play a part in maintaining the sphincter action do not take part in vocalization. This sphincter tends to stay open when the epiglottis is upright and close up when the epiglottis inverts.
The main function of mastication is to grind big or coarse particulate material and mix it with salivary secretions to form a cohesive bolus of acceptable consistency that can be brought over the anterior tongue. The anterior tongue takes on the shape of a spoon or shovel ready to convey the bolus to the next stage, the back of the tongue. During this time, the buccinators squeeze in the oral contents from the lateral cheek sulci into the intradental arch and onto the anterior part of the tongue. The lips seal up to prevent drooling and loss of bolus. If the oral bolus is too large, part of the buccal contents are retained in the extradental lateral sulci for the next bolus. The action in the anterior buccal region is totally under voluntary control. The subject can spit out all or part of the buccal content. In the next stage, the bolus is conveyed to the posterior part of the tongue and into the oropharynx, from where voluntary control is lost. The oropharynx extends from the faucial pillars to the vallecula. As the bolus reaches the lateral pharyngeal fauces or lateral pillars, the swallowing reflex is triggered, starting a peristaltic wave. From then on, the function is autonomous. These lateral pharyngeal pillars also act as guardians and controllers of the swallowed bolus. If there is a dangerously large particle or irritant matter, the pillars, which normally move toward each other to offer a narrow, compact doorway, close up into a spasmodic contraction. This is called gag reflex, which is associated with an effort to get rid of the foreign matter from the buccal cavity. The posterior part of the tongue, which was elevated, now sinks down, allowing the bolus to travel over it to fill the valleculae and the oropharynx. At this time, the soft palate, called the velum, moves up and posteriorly to seal off the nasopharyngeal opening. At the same time, the hyoid bone is pulled upward and anteriorly. This hyoid movement sets up a very crucial chain reaction that links the buccal lingual and pharyngeal dynamics with the laryngeal movement. The hyoid bone is connected by dense fibrous bands to the thyroid cartilage. Dense fibrous bands also connect the cricoid cartilage to the thyroid cartilage. Therefore, the upward and anterior movement of the hyoid bone produces similar movement of the thyroid and cricoid. As the cricoid is pulled upward and anteriorly, it pulls up the esophageal opening along with it. Normally, the anterior airway tube and the posterior digestive tube lie under the epiglottis. The oropharynx and the laryngopharynx comprise a mixed aerodigestive tube. The air going down the digestive tube creates no trouble, but swallowed food or fluid in the airway can create a situation of drowning. Epiglottic inversion. The bolus in the valleculae is tipped down the epiglottic chute as the epiglottis inverts downward onto the esophageal opening, which has been pulled up and anteriorly to lie directly under the epiglottic chute. The airway tube is closed up by the intrinsic laryngeal sphincter. This sphincter acts to close the airway when the epiglottis inverts and open the airway when the epiglottis is erect. A protective choke reflex is triggered when solid or liquid foreign body penetrates the vestibular sphincter and comes into contact with the false vocal cords, the true vocal cords, or the laryngeal ventricle between the two. The bolus then enters the hypopharynx, filling the pyriform fossae on either side, which form part of the two lateral food channels, namely right and the left, and lets the bolus travel down. Ideally, at this time, there is timed relaxation of the inferior fibers of the cricopharyngeus muscle, which take place as the bolus, which was carried down the oropharynx and the hypopharynx, reaches the esophagus. The hyoid, which moved anteriorly and upward, then posteriorly, now moves downward, dragging the larynx with it, descending down to its original position with the rest of the larynx. Now the hyoid waltz movement is completed. The return of the hyoid bone and the larynx is made possible by the action of the sternohyoid, omohyoid, and sternothyroid muscles, collectively called the strap muscles. The epiglottis spontaneously returns to its normal upright position. The intrinsic laryngeal vestibular sphincter relaxes and opens the airway. The bolus, once deposited into the esophagus, is carried down, aided by the primary peristalsis, and later assisted, as and when needed, by the secondary peristalsis. The swallowing sequence is very rapid and involves many complicated mechanics. In a normal person, it takes less than 1 second to complete. Video or rapid cine documentation is a necessity to study the normal and abnormal swallowing mechanism. Radiological study offers the best and simplest means of finding the causes of swallowing difficulty and the type of impairment and localize it. For the evaluation of dysphagia, the study is done by giving a very small quantity of A. very thin barium, B. thick barium, and C. barium mixed with cracker. The consistency of barium not tolerated can point to the type of food the subject should avoid or be careful with. The study should be done preferably in an upright position. Cine or video recording should be made in absolute AP and lateral views. Any changes with head position, for example, extension, flexion, and right and left side rotation, are additionally helpful. If the study cannot be done in the upright position, the patient may be examined in the horizontal position. If aspiration is a major problem, a study in Trendelenburg position has proved to be useful. Throat suction needs to be done after the study is completed. A normal swallow in a lateral position is demonstrated. The oral phase, the pharyngeal phase, and the hypopharyngeal phase are seen to function smoothly, and there is smooth transfer of bolus into the esophagus. There should be no retention of bolus in the mouth or pharynx or larynx. A normal swallow in an anterior-posterior position is now demonstrated. There should be a quick transit of bolus in the vallicular and the pyriform fossae. Both should appear symmetrical in shape and size and not retain any part of the bolus. There should be no laryngeal penetration. The epiglottis should invert and revert promptly. The bolus from the two pyriform fossae, which form the right and the left lateral food channels, should enter the esophageal opening in a smooth manner following the cephalocervical deglutitional peristaltic wave. There should be a coordinated opening of the mouth of the esophagus, which is also called the upper esophageal sphincter. This brings us to the end of the normal swallow. If you have successfully swallowed the contents, you are now ready for the next topic, now available, titled Mechanism of Abnormal Swallow.
Food is the first and major preoccupation of all species, human or not, influencing all ages from the moment of birth to death. There is therefore enough in-mouth training for the swallowing ability to function well. Good swallowing helps to nurture health and prolong life, whereas abnormal swallowing promotes illness and cuts life short. All can't swallow well all the time. Most can swallow well most of the time. Some can't swallow well most of the time. There are, however, some who can swallow anything at any time. We offer you the Oriental Spicy Show of one of these people who can swallow anything, including live frogs and live snakes, with no trouble. Most human beings will encounter some swallowing difficulty at one time or another during their life. Even those who have no problem with their swallowing may have underlying occult dysfunction, which is covered up by compensatory adaptive mechanisms. A cine or video study of their swallowing mechanism may bring to light the underlying problem, which may become symptomatic when their compensatory adaptive mechanism fails.
Difficulty in or during swallowing is called dysphagia. Pain during swallowing is called odynophagia. Swallowing dysfunction can exist without either dysphagia or odynophagia and be brought to light by the cinebarium swallow. Bad eating habits such as inadequate mastication, hasty gulping, inattention to eating, swallowing multiple tablets or capsules may undermine the normal swallowing mechanism. An increased or abnormal sensory afferent stimuli from the mouth, nose, pharynx, hypopharynx, and even the esophagus may induce multiple or uncoordinated abnormal swallow response and may result in dysphagia or swallowing dysfunction. In a normally and effectively functioning oromotor mechanism, the tongue and the teeth can identify and isolate even a small hard foreign body or a fish bone so that it could be spat out or consciously ground to a pulp.
There are 3 safety reflexes against an invasive bolus during swallowing. The gag reflex arising from the buccopharyngeal junction, the choke reflex arising from the intrinsic laryngeal sphincter, the cough reflex arises from the trachea. These, when breached, set up a safety and panic response. If solid or liquid enters the larynx and reaches the false or true vocal cords, it produces a spasmodic contraction of the intrinsic laryngeal muscles that shut off the airway. This can, in severe cases, lead to syncope or death. This choking phenomenon is also called the cafecoronary, as the choking due to aspiration is often seen in cafeterias and eating places. It mimics a coronary occlusion or a heart attack. Heimlich maneuver applied in time is a life-saving procedure. Heimlich maneuver consists of applying sudden compression to the epigastrium in order to produce a sudden air expulsion from the stomach and chest to dislodge the foreign body from the laryngeal region. If the foreign material enters the subglottic portion, namely the trachea, it sets up a violent cough reflex, which even without the ciliary action tries to propel the foreign matter out of the airway forcibly. During these reflexes, there is tremendous increase in the intrathoracic and intra-abdominal pressure, which can create other problems, such as pneumothorax, collapse of the lung, rupture of any diseased blood vessel, rupture of the esophagus, or fracture of the ribs. Swallowing problems may be dramatic and easily recognized, or be subtle and silent, yet sinister. Aspiration pneumonia, lung abscess, and necrotizing pleuropulmonary complications are commonly seen in patients with swallowing problems. A person suffering from chronic silent aspiration